Again, good evening, everyone. We'll be starting in a couple minutes. We're so happy to have you with us today. Good evening again. We'll be starting in about 1 minute. We're so happy to have you here with us. Good evening. My name is Dornay Hill. I am the Senior Administrator for Crisis and Trauma Services here in Montgomery County, Maryland. We are so happy to bring to you another session of our mental health and community wellness conversations, healing and holding on to hope, one community conversation at a time. We are very excited today to be having a conversation about mobile crisis outreach teams, the CAHOOTS model from Eugene, Oregon, and also how we here in the county intend to incorporate that into our mobile crisis continuum of services. First, we will be hearing from Dr. Raymond Kroll, who is a clinical psychologist with more than 30 years of experience in human services. He is currently director of the Montgomery County Department of Health and Human Services. He has a doctorate from Rutgers University and his undergraduate degree in psychology from his home state at the University of Michigan. He has written and published on behavioral health and healthy development for African Americans, on building supportive housing for the chronically mentally ill, and completely by being in the wrong place at the wrong time, he became an annual guest on the local radio stations such as NPR between Thanksgiving and March, discussing seasonal affective disorder. I had the honor for the past 10 years prior to his appointment of having Dr. Kroll serve as the Chief of Behavioral Health and Crisis Services here in Montgomery County. As the chief, he was responsible for the development and management of mental health, substance abuse, trauma, crisis, and victim services. Without further ado, Dr. Kroll.
Thank you, Ms. Hill. A pleasure to be with you all this evening. And I want to say thank you for taking the time to come out. I have been I was the chief of behavioral health for 10 years before I became the director of the department. And those were, I think, 10 of the most exciting years of my career. I can honestly say that I did not have a dull moment, a boring moment in the entire 10 years I was there. And we accomplished a lot of interesting things and went through some hardships. I want to back up. I've been a psychologist for 30 plus years, almost 40 now. And one of the things that has been a painful reality of my professional career is watching the mental health system in this country gradually erode. as it gave way to managed care and as it gave way to deinstitutionalization and the failure of the country as a whole to embrace the idea of community mental health as a service system, I watched money flow out of the system and resources flow out of the system over those 20 years, and watched people go into the streets and begin to live on the streets who had mental health issues and mental illness, and watched their hopelessness evolve over time. I also watched the evolution of law enforcement as a source and as a route for getting treatment to folks, to the point where a common theme was that jails were the largest psychiatric hospitals in any given region, just because of the numbers of people that they had that police had faced with no option other than to arrest them and have them incarcerated so that they could get into treatment and at some level. That is, Montgomery County was not exempt from that. The last 10 years, we have struggled a lot to try to build systems where we could that would divert people from the jails and create opportunities for them to be treated elsewhere. Sadly, in the time that I was chief, we went through probably in 10 years that I was chief, we went through about 8 years of budget reductions and budget cuts that impacted the crisis center. We had at one point mobile crisis, two mobile crisis teams plus an outreach team that was referred to as the Public Inebriated Initiative to go out on the streets to engage people and get them off the streets and get them to safety and get them engaged in treatment. Budget cuts over the years eroded that. We lost staff, we lost the budget teams, we lost the capacity to field anything but one team in mobile crisis. This pandemic and the things that we have witnessed in terms of interactions between law enforcement across the country and folks on the streets with mental illness, and the voices of advocates such as are likely in this room tonight, hopefully in this room tonight, have led us to the point where we are now beginning to recognize and rebuild, recognize the need for and rebuild a mental health service that the county deserves. Councilmember Hucker started that process off a little over a year ago with 6 positions to expand, giving us the opportunity to expand our mobile crisis teams. You'll hear a little bit about Dr. Santiago and Ms. Hill's efforts to grow that and grow it even further. Our goal is to try to build a system that has the capacity to respond to the needs of people on the streets and in the community in ways that are safe and in ways that don't necessarily always involve law enforcement, because not everything needs to involve law enforcement, as you will hear. There are some cases where law enforcement is important. There are also cases where, and their presence is important and necessary, but there are cases when we can do this with civilian responses, with mental health, with trained mental health professionals and with peers and with fire and rescue support, emergency medical supports. So you'll hear a little bit about that tonight as Dr. Santiago and the team talk a little bit about this. And then you'll hear from our folks in cahoots who will talk with us about their experience and you'll get a sense of how we're going to draw on their experience as we build out a system that works for Montgomery County. So I'm looking forward to a great discussion this evening. And with that, I'll turn it back over to you, Ms. Hill.
Thank you so much. So next we will hear from Dr. Rolando Santiago, who is the Chief of Behavioral Health and Crisis Services and my boss in the Department of Health and Human Services here in Montgomery County, Maryland. He is responsible to oversee all behavioral health prevention, treatment, crisis, trauma, and recovery services for the county. He brings an invaluable experience in the management, evaluation, and research of behavioral health services at the local, state, and federal levels. You're on, Dr. Santiago.
Good evening, everyone. My role tonight is to give you a brief update about the development of the Crisis Now model here in Montgomery County, which is the model that we're using to implement and expand the mobile crisis and outreach teams. The Crisis Now model is a nationally recognized approach to responding to behavioral health crises. This model helps divert people who are in crisis from landing unnecessarily in emergency rooms or jails. It is also an equitable way of approaching crises so that people from any of our diverse communities here in Montgomery County can have access to crisis services. There are three important components of the Crisis Now model that I want to talk about. The first component is an integrated regional call center where it doesn't matter if you call 911, Crisis Center Hotline, the National Suicide Hotline, or 311, you will get the same answer. The second component is mobile crisis outreach teams. These teams consist of first responders who are trained to address people who are experiencing a mental health or a substance use crisis. And the third component is a stabilization center. The stabilization center is a place where a person spends 1 to 3 days recovering from a crisis. It's an alternative to an emergency room or even to jail. So let me update you briefly on what Montgomery County is doing to develop these three components of the Crisis Now model. First, regarding the integrated regional call center, the CAHOOTS staff from Eugene, Oregon, are helping us to create a common triage protocol for emergency communications. This protocol will help with the collaboration needed between our 4 crisis call centers, like I said, 911, Crisis Center Hotline, the National Suicide Hotline, and 311. Second, regarding the mobile crisis and outreach teams, the Crisis Center is expanding these teams. Instead of having just one 24/7 team, like Dr. Kroll mentioned, we will have 3 teams. The new teams will start this Monday, August 30th, at 2 new satellite locations, the Down County in Silver Spring and Up County in Germantown. And then third, regarding a stabilization center, the county has initiated planning for a restoration center. This center will stabilize individuals during the first 24 to 72 hours after a crisis. This is a construction project and it'll take time, but it will add a much needed resource in Montgomery County. With this summary, let me turn it back to Dornay Hill.
Thank you for that. And I'm so excited about the work that we're doing here in the county. So this evening, we have 3 dynamic speakers who are going to talk to you about CAHOOTS, the crisis assistance helping out on the streets. And we have Tim Black, who is Director of Consulting at the Whitebird Clinic, with a background in runaway and homeless youth, harm reduction, and street outreach. He began working for CAHOOTS as a crisis intervention worker in 2010, before moving into an administrative role as the CAHOOTS Operations Coordinator in 2015. His work with the Whitebird and CAHOOTS has put him in touch with the cities across North America, looking to implement services based on the CAHOOTS model of behavioral health first response. Programs based on the CAHOOTS model have been implemented in Olympia, Denver, San Francisco, and Portland. In addition to his work with Whitebird Clinic, Tim is active in homeless advocacy and also serves on the board of directors for Eugene's community support shelters. We also have 2 local speakers, Beth Tabachnik, who is a clinician for the Crisis Center, who is embedded at Montgomery County Police Department in the Crisis Intervention Team. She earned her BS in psychology from Fordham University, a master's in social work from the University of Maryland, Baltimore, and her certification as a clinical social worker in 2004. Beth began her career in social work as a staff therapist at the Montgomery County Crisis Center, providing individual and community crisis intervention services in mental health, domestic violence, and trauma response. During her 12 years at the Crisis Center, Beth also serves as a co-coordinator for the county's crisis intervention team training program, which enabled her to transition smoothly to her current positions, assigned full-time as a clinician with the Montgomery County Police Department's Crisis Intervention Team, where she assists with clinical evaluations, training of sworn and non-sworn officers, and community engagement initiatives. Beth also continues to work part-time at 2 local hospitals conducting behavioral health assessments in the emergency department. And last but definitely not least, we have Ben Stevenson, who also is a county employee, who is the Prevention and Harm Reduction Manager for the Montgomery County Department of Health and Human Services. He will help us explore the landscape of opioid use disorders and provide information on harm reduction services that assist individuals and their families who are affected by drug use here in our county. In his role, Mr. Stevenson plans and coordinates prevention efforts to educate and raise awareness of the dangers of substance abuse and use. He is a certified prevention professional who has worked in the substance use prevention field for more than 15 years and has worked with thousands of individuals, professionals, and families and communities across the United States. Under harm reduction services, Mr. Stevenson and his team work to educate the public about opioid use disorders, including how to spot the signs of an overdose, how to help someone experiencing an overdose, and engaging individuals who misuse drugs and harm services. After or during this presentation, we also hope to hear from our county executive, Mark Elrich. But without further ado, Tim, thank you, and it's on you.
Thanks, Dornay. I really appreciate that introduction. And thank you all for taking some time out of your evening this Wednesday to engage with us in this conversation. I think it's really important that we take some time to really think about and look at what cahoots services are here in Eugene and Springfield, Oregon, in order to really reflect on what it is that Montgomery County is going to need to do with regards to its own, mobile crisis outreach teams. I think it's really important to recognize that, no two communities are the same, and as such, every mobile crisis outreach team is going to have inherent differences to it. So, my hope is that over the next few minutes, I can take some time to really elaborate on what it is that Whitebird Clinic and the Cahoots program do here to inform more about, the work that's going on in Maryland. The very first thing I need to do is really offer a very brief history lesson to really kind of understand how we got to the place that we are in today. In the late 60s, Eugene in Oregon was experiencing a lot of the same, kind of cultural upheaval as a lot of other communities were, particularly on the West Coast with regards to the Summer of Love. When our founders started to really kind of look around the landscape in Oregon, really recognizing that being on the I-5 corridor, literally halfway between San Francisco and the Canadian border, meant that we were getting a lot of folks, kind of filtering through, and with that, an influx of housing needs, of mental health, of substance use and abuse, and there was this real recognition by our founders that the existing system just wasn't working and wasn't equipped to be able to respond in the ways that folks in our community needed, and so to really respond in a different way, our founders spent time in San Francisco at the Haight-Ashbury Free Clinic, and also went up to Portland and spent some time with what at the time, in 1969 was a new program with Outside In. And from those lessons learned from day centers and from free clinics in the Bay Area, we really developed a new community-based clinic that would respond to all manner of situations that were, being experienced by, variety of community members. Out of that initial desire to provide some sort of community-based response, one of the things that we saw a need for was there to be a mobile crisis team. We had a crisis line that folks could call, and in order to really be able to respond in the most appropriate way, there were situations where we needed folks to be able to go out and actually interact in the community with somebody. Using the vernacular of the early 70s, we called this a bummer squad, and that was really kind of the first step towards what became the Cahoots program. The Bummer Squad was a volunteer-led initiative without any sort of funding, and it wasn't until the late 80s when there became a community policing grant available from the city of Eugene that we were able to really formalize what we were doing. And it was through this kind of opportunity, this partnership, the opportunities that public safety saw to work alongside, community organizations gave us an opportunity to really branch out, really kind of build on that trust that the community had with us. There are 4 real main guiding philosophies for the Cahoots program and Whitebird Clinic at large that are really interconnected and really inform a lot of our successes as a service provider out in the field. And that starts with a recognition that everything that Whitebird Clinic does needs to be client-centered. We employ a harm reduction model in all manner of services, whether that is the outpatient substance abuse treatment program or our counseling, our medical clinic, our dental clinic. Whitebird Clinic has a lot of different services, and we all, at every level are really, again, reinforcing a harm reduction approach and really striving to provide trauma-informed care. The other thing that really sets us apart as an organization, both on a local level and on a national level, is really this idea that in addition to providing alternative services, we can also provide an alternative structured organization. As such, we operate as a consensus-based collective. And that means that, being client-centered, using harm reduction, being trauma-informed are things that we need to do with each other in order to be able to run our business. And that allows us to really, hone these skills that we're using on a day in and day out basis. Now, specific with Cahoots, it's important to really kind of talk about our staffing model. Whenever you see one of our teams out in the field here in Eugene or Springfield responding to calls for service, you notice that there's always going to be 2 staff in the van. We always staff our response teams with an EMT, at least a basic or higher, and a crisis intervention worker. Our crisis workers don't need to have a master's level credentialing. What we're looking for is the equivalent of a qualified mental health associate credential in the state of Oregon. Regardless of what kind of background folks come to us with, everybody who's new to the Cahoots team is going to go through about 30 hours of training in the classroom, where we're really focusing on a lot of the logistics, the operational side of things. How do you use a police radio? How do we approach de-escalation in a hands-off fashion? We take a lot of that classroom skill and knowledge, and then over 500 hours in field training, apply those skills incrementally. And that really allows our staff's opportunity to really kind of grow into the role and find their voice as a responder on Cahoots. Every single member of our team is unarmed, and so that means that whenever we're out taking calls for service, we're not wearing a vest, we don't have a taser, no pepper spray, no concealed handguns. This is a completely unarmed response. And for our patients, it's also really important to recognize that our emphasis is on support and stability in that moment, ideally even in the field, really being able to provide resolution where somebody is in the community, being mindful of the impacts of displacement when you take somebody across town, for instance. And we do all of this work through the lens of least intervention necessary. This means that we're not going to be inflicting help on somebody. I think this comes from my days in wilderness therapy. Knowles has this saying, your crisis is not my emergency. And what that really means is that we need to sit down and take a very grounded look at what's going on, and then work together to identify what are the realistic things that we can accomplish together today. What are the things that we're going to need to help you find another resource to be able to handle later on? When it comes to the things that we do, this slide here is a really good attempt to encapsulate the various services that Cahoots responds to. This is not an exhaustive list, and it's not a guarantee that our teams are going to be able to handle are going to get dispatched calls for every bullet point that you see here. But a couple of things I would really highlight that are really impactful in our role as first responders in the larger system are primarily around grief and loss and welfare checks. We talk a lot about suicide, other mental health crises, a lot of conversation around addiction, but grief and loss and welfare checks are an area where mobile crisis teams have an opportunity to have a larger role. With grief and loss, this means that in Eugene and Springfield, nearly every single death notification that occurs is facilitated by Cahoots as opposed to a uniformed officer. Additionally, with welfare checks, we've been able to get to a place where in our community, whenever possible, unless there are indications that there is a medical emergency or a violent crime in progress, Cahoots teams are dispatched as the first responder for every subject down call in our community. That means anybody who's not actively up and moving around. And that allows us to have a lot more of those kind of first touches with somebody, as opposed to really tying up resources that are much more expensive and are much more appropriate for other higher acuity situations. You know, we're not tying up those resources to go wake somebody up and check on them, see how they're doing. In addition to all of these different, resources here, we also do, a lot of collaborative response with other public safety resources. And the reason that we're able to do that so effectively is because we are so integrated into the larger dispatch system. In Eugene and Springfield, all Cahoots calls for service are facilitated through the public safety answering point. So that's non-emergency dispatch. We aren't a 911 service. We don't go lights and sirens, so we tell people don't call that number, but we do use the public safety dispatch system. And that means that every call for service, not just the ones where somebody is explicitly saying, I need Cahoots, but every call that's coming through dispatch is being screened to determine, is this something that a Cahoots team should respond to and be able to handle? When those calls are determined to be appropriate for a Cahoots response, they're triaged for acuity level, relative to everything else that we might have going on that day. And then our teams are being dispatched over radio on non-priority police channels, but on frequencies that are shared by other public safety resources. And that allows us to be able to call for cover when we need it and to be able to bring in the other resources that we might need in order to, really effectively intervene. I think it's important to spend some time talking about what the actual impact is. And I will try to be brief because numbers can be really dry and there are a lot of them. But looking at our role in the larger public safety system, we can see, if we look at the numbers that were published in 2019 by the Eugene Police Department, that there were 105,000 calls that were placed to the Eugene Public Safety Communications System. Out of those 105,000 calls, Cahoots teams responded to nearly 18,000 of them. 15,000 of those calls were situations where Cahoots responded as the sole resource. That means there's about 3,000 calls a year that we're taking with either police officers, on patrol, or with fire and EMS apparatus. Out of those 15,000 calls that we took without those other public safety systems involved, 13,000 of them would have required police or fire and EMS to respond. The Eugene Police Department estimates that our diversion rate is about 5 to 8%. And when you think about that in regards to that 105,000 calls that came through, they're saying that about 5 to 8,000 of the calls that we responded to were what they consider to be a true criminal legal diversion. There was arrest avoided, or, at very minimum, this is something that an officer would have likely, handled. What I think is really fascinating about that is that still leaves about 10,000 calls a year that we're responding to where things haven't gotten to the point yet where we are worried about arrest. And so that really speaks to our level of prevention. And this is something that you will hear if you, are able to catch, for instance, an interview with Chief Skinner from the Eugene Police Department. Within all of that work, within those thousands of responses that we take a year, the fact that we're probably taking on average about 10 calls a day from the police or fire departments, it's important to recognize that we only called for police cover 311 times in that same calendar year. That's less than once a day. And it's a pretty even split between situations where we were encountering violence and aggression and those where we had somebody who needed an involuntary hold to get to a higher level of care in order to be able to maintain safety. We are subsequently diverting a lot of folks from the emergency room and from, the jail. And when it comes to our ER diversions, we've been able to really quantify those cost savings to our community, which we'll touch on the next slide. But what's really important to recognize is that this mobile crisis response is having such a huge impact, reducing population health spending, improving outcomes for folks. As part of a larger continuum of services in our community, we're also going a long way to really address social determinants of health. We could go into, and I could probably spend an hour and a half talking about each of these different bullet points here. So I'll save, kind of further exploration for the Q&A if folks are interested in that. It is, though, important, and I do want to emphasize the exact cost savings that we estimate we're bringing to our community from those emergency room and ambulance diversion savings. And so in our own evaluation of the Cahoots services, we estimate that we are saving our community $14.8 million a year just in hospital and ambulance diversions alone. Within that 14.8 million that we are estimating, that we're saving our community, our calculations show that $4.1 million is being saved directly by Medicaid in our community, and has been part of the reason that we've been able to get Medicaid to come to the table a little bit more to support us with some wraparound services funding that ultimately results in better supplies for our patients out in the fields. We also do a lot of work around criminal legal diversion, as I mentioned. The Eugene Police Department estimates that in just labor from officers alone, we are saving the police department $2.2 million a year. And again, just like with the ER diversion, there are a lot of very specific situations that could be their own, 90-minute presentation that really go into how our services are, really affecting the larger system, and how, how important mobile crisis is in public safety, in general. Now, through all of this work, through these thousands of calls a year that our teams are responding to, through these millions of dollars that we are saving our community, I can't stress enough that this work can be done safely, and with that high degree of responses, with that high degree of interactions that we're having with the public on a daily basis, we've never had a serious staff injury as a result of patient contact. There are occasional scuffles, and honestly, this may be my bias coming through a little bit, but when those scuffles do occur, generally we're able to point back to really recognizing that the person in crisis was feeling such profound powerlessness, that they were trying to find some way to at least have a little bit of physical autonomy in that moment. But by emphasizing in our training worker safety as much as we do, through environmental awareness, that allows us to really evaluate an entire scene, through clearly communicating not just with our work partners, but with our partners in public safety over the radio, driving defensively, looking differently than traditional public safety systems. These are the things that really have allowed our teams to stay safe day in, day out, night in, night out for 32 years. We put a really big emphasis on really trusting your gut, really kind of going with that spidey sense. If something feels off, it probably is. And it's perfectly okay to take a step back and say, hey, we got to look at this again. We need to take a little bit different approach, or maybe this just isn't working out. Maybe we're not the right folks for that person to talk to. Maybe the person in crisis just doesn't like short guys with glasses and beards, and that means that I'm not the responder, for that situation. We utilize verbal de-escalation, so we're not expecting our folks to go hands-on with the folks that we serve. And finally, and this I think is something that really gets overlooked in a lot of these conversations around safety for responders, is about what happens after the call, right? There is safety to be considered for folks experiencing this level of vicarious trauma. And so self-care and clinical debrief become really vital to, the success and longevity of a career with the Cahoots program. And in particular, we've made a really concerted effort in the last 10 years to really destigmatize accessing therapy and mental health resources as responders ourselves, and are starting to see some changes within the public safety system at large, where folks are becoming more comfortable kind of talking about the impact of the work on them. In addition to all of that dispatch, calls for service that our teams are responding to in our service district here in Eugene and Springfield, that's not all we're doing, and I think that the final two things that I would really like to touch on are where we have had to go and engage more in direct patient advocacy, and one example of our really collaborative efforts to address other service gaps in our community. With regards to patient advocacy and our role in the community, anytime there's some sort of a large group gathering where there are multiple service providers, really, just a gathering around a population or specific themes, there are going to be Cahoots representatives there to make sure that we are speaking up for those who are being affected by service delivery from other providers, speaking up on behalf of those slipping through the cracks, advocating for, commitment and on occasion, really just trying to make sure that we are plugged into that larger system, because the success of Cahoots, the ability to divert as many folks as we have from that larger system, is predicated entirely on our ability to connect and work with these other services. And the final thing that I would really like to touch on here is what we do when we see those service gaps. Your mobile crisis teams are inherently going to be eyes and ears, really experiencing a lot of the direct fallout if there is a lack of, any number of resources in the community. Here in Eugene, we have one of the highest rates of homelessness per capita in the entire United States. And what that means is that we are constantly in situations where housing is at the crux of the crisis, right? It's about addressing that most basic human need of shelter that is what's going to make or break, this person getting into the hospital or finding some resolution out in the community. And in order to really address that, there are two things that we've done. One is short-term shelter. The other is longer-term shelter. With regards to short-term shelter, we've been able to partner with another organization that builds these huts that you see here. This is about 60 square feet of living space. These huts are generally placed in church parking lots or, fire stations, other businesses that have a large parking lot with porta potty and a dumpster. And this allows us to lodge somebody in a place where they have a door that locks, safety, and stability. And that means that other services can then come to them. An assertive community treatment team knows that, okay, we can go find Tim at his hut at the fire station on Chambers Avenue, right? So, in the short term, we've been able to work together police department funding to build the huts, collaborations between Whitebird Clinic and Cahoots and other services to find the locations to place them, and then really recognizing those most in need getting placed in these huts. On the longer term side, we have started to work with another housing provider in town specifically to address housing for families, and are seeing that as with the wildfires coming through Oregon, there's more and more need for that. So that really wraps up the slides that I have today. I've got one more here with some contact information on it. If you want to learn more about the program and talk to us directly, you can find us on the website. And with that, I'll turn it over to you, Beth, to talk about crisis services.
Thanks, Tim. I think that there may be a slight change in plans. I'm just waiting to hear.
Nope, you can go ahead, Beth.
I'm sorry?
You're good. You can go right ahead.
Oh, okay. I apologize. I thought there might have been a slight detour there. Okay. My name is Beth Tabachnik. As Ms. Hill had introduced me earlier, my name is Beth Tabachnik, and I have been lucky enough and privileged enough to be a clinician in the county for approximately 20 years now. I am very honored to be here tonight participating in this conversation. It's been a really challenging time in mental health, particularly emergency mental health services, and we've had some very dynamic and complex conversations around what the next steps need to be or should be to help make our communities safer and to help our residents have the best access to services to live healthfully. So I'm really excited to be here just to discuss a little bit about both mobile crisis outreach expansion, and then also what I've been doing primarily for the past few years, my role within the Montgomery County Police Department's crisis intervention team and some of the work that we've been doing. So I'm just going to start by providing a little bit of an overview of crisis center services. And for many of you who live in Montgomery County or who have accessed mental health services in Montgomery County, you might already be pretty familiar with the crisis center, but it's really important that we stress what the crisis center is and where it's located and how to access it. We are very lucky to have this resource in our county. Ms. Hill provided a very thorough introduction, but what wasn't mentioned was that I actually started my career in my infancy at the crisis center. I did both an undergraduate and graduate school internship at the crisis center, and so I've really been connected to the crisis center for many, many years, and I am very proud of the services it's provided to the community. The crisis center, as many of you know, is located in Rockville. They have it's a first floor office where you enter on Picard Drive, and it's open 24 hours a day, 7 days a week, 365 days a year. It never closes. So even when all other county services are closed for holidays or for inclement weather, there are staff at the Crisis Center manning both the phone lines and also providing emergency services for those who walk into the building. And this is a tremendous resource to know about. You don't need an appointment. You don't need to call first. You can just walk in and speak with a clinician who can help you explore the situation and see what the best resource might be. They primarily focus on mental health evaluation and stabilization. If you are having a mental health emergency, if you know someone who's having a mental health issue, the therapist can kind of talk you through that. They'll do a thorough assessment of the situation and see what the best possible resource might be to help address that challenge, and hopefully help sort of bridge that gap in terms of getting you connected to resources. As Dr. Kroll mentioned in his introduction, the mental health system is an extremely complicated and challenging system to navigate, even for those of us who are trying to do so under the best of circumstances. But for many of our clientele, for many individuals, when they're attempting to access these services, they're really at a point where it's incredibly difficult to kind of even know what the first steps are to take. And so the Crisis Center staff are available and ready to help assist with that process. You don't have to walk into the Crisis Center. You can call the crisis phone lines that are also operational 24 hours a day. When you contact the Crisis Center, you do speak with a mental health professional live. You may hear a recording initially to kind of to give you a little bit of a prompt, but then a clinician will answer the phone and will be able to immediately provide some guidance in regards to your situation. And part of that guidance might be to encourage you or the individual seeking assistance to walk in for further assessment. But you can certainly contact them via phone first and explore the situation with the clinician who answers the phone. And again, those phones are answered 24/7. The Crisis Center also has residential crisis services. I'm not going to go into this in any great depth right now, but I just want the community here to be aware that there are crisis beds that are actually located at the Crisis Center. Crisis beds are often used either as an alternative to hospitalization for individuals who are in some level of distress, some level of perhaps psychiatric destabilization, but not necessarily requiring full inpatient treatment, or perhaps coming out of a hospitalization where further stabilization and structure and support is helpful prior to returning to their living situation. So there are beds located at the Crisis Center that provide this service as well. Some of the community providers also have crisis beds at other locations in the community, and those can be explored by contacting one of the clinicians at the Crisis Center and inquiring about how to best access that and whether the situation would be appropriate. The Crisis Center also provides is a point of entry for many other county programs. It's really the only 24/7 county program. So if you have questions or if you're looking to access the emergency shelter system or the domestic violence, if you're in a domestic violence emergency and are looking to develop a safe plan for managing that situation, the Crisis Center is the best first point of contact. They also offer assistance to after hours and on weekends to our victim assistance and sexual assault program and our adult protective services and child protective services lines. If you contact those lines after hours, you may initially reach a Crisis Center employee who will connect you with those services. Okay, just to continue, they also employ psychiatrists on site. If there's an individual, we all know that accessing psychiatric care can be extremely challenging. It often takes quite a long time to access an appointment with a psychiatrist in the community, and the Crisis Center does have psychiatrists on staff for individuals who have state insurance or who do not have insurance at this particular time. They may, after meeting with a clinician who assesses their situation, they might be scheduled to see one of the psychiatrists. And I'm going to skip ahead, and we're lucky, the pandemic has created a lot of challenges over the past couple of years, but it's also created some opportunities. We've developed a more extensive telehealth program where appointments are able to be provided to folks via telehealth, which certainly is tremendously convenient for some individuals. The point I just want to make about community outreach and education, unfortunately, sometimes we experience situations in the county that are very, are very traumatic or troubling. And the Crisis Center also, the staff therapists there also provide some form of critical incident response. They can respond on site if there's a situation in the community that's very difficult. When I started my career at the Crisis Center, it was just shortly before the DC sniper situation, and that's a situation certainly that was very impactful to our community, and we did a tremendous amount of on-site support and community outreach during that situation. They continue to do so for different types of traumatic situations that come up. And the Crisis Center is available for all county residents. You can just, like I said, you just can walk in and ask to speak to a staff person or call on the phone. Okay. I'm not going to go into this in any great depth. We just wanted to include this slide to show that the Crisis Center employs a multidisciplinary staff. The licensed therapists or clinicians are master's or doctoral level mental health professionals. They also have some support staff who provide assistance with managing the daily operations of the Crisis Center. I already mentioned that we have psychiatrists who are on staff there. And so it really has been a very professional service to offer to the community. The staff who work at the Crisis Center are cross-trained. If they're working in the office, they may see, the same staff who are trained to work with our crisis beds or see the walk-ins are also trained to go on mobile crisis outreach calls. Sorry, can you forward this? There's a chart that goes with this. Thank you. So again, not to go into numbers to any great extent, I think that fiscal year 17 to fiscal year 21 is very challenging, in terms of looking at stats, because obviously the past couple of years have been extraordinary in terms of the pandemic and the incredible need for mental health services. You may notice in through fiscal year 20 to 21, the number of walk-ins at the Crisis Center actually decreased, but the number of calls, mobile crisis calls, and critical incident responses increased. And I would anticipate that that trajectory will continue. Okay. So this slide, and I'm sorry if you could continue to put up the information. Thank you. This slide is probably the most important in terms of kind of what we're here tonight discussing. We all want to talk about mobile crisis outreach and the service that this provides to the community. This is an incredibly important topic right now. As Drs. Kroll and Santiago and Ms. Hill had mentioned previously, the Crisis Center is currently going through a period of expansion in terms of mobile crisis outreach services. This will be hugely important to the community. Previously, we had one office-based team in Rockville, which is centrally located in our county. For those who are familiar with Montgomery County, you know how difficult traffic and other considerations can be when moving throughout the county. There can be some delay in responding to different geographical areas, and it's also a community of over 1 million people. So we really wanted to make sure that it's very exciting to think about being able to offer increased capacity with our mobile crisis outreach team and to be more available and to be more immediately available to the different geographical regions of the county. Historically, and we can certainly talk about this a little bit more in depth if there are questions. My fellow presenter talked a little bit about the CAHOOTS model in terms of their model of response. many of you may know, historically, when the crisis center clinicians have responded to mobile crisis calls, they have co-responded with law enforcement officers in our community, whether that's Montgomery County Police or Rockville City, Gaithersburg City, Tacoma Park. When the crisis center staff have gone out on calls, they've requested backup assistance from officers who respond to these calls with them. We've had that partnership in place for many years. Our MOU with the Montgomery County Police Department started back, I believe, in early 1999, and our formal MOU with the police department. So that's been something that's been in place for quite a long time. The purpose of our mobile crisis outreach team, obviously, is to assess for immediate crisis issues, immediate safety issues, to determine the most appropriate disposition for an individual having a mental health emergency. Many times in these situations, family members, loved ones, perhaps staff on site in a facility are overwhelmed or concerned, for an individual who may be acting in a way secondary to their symptoms that present some safety concerns for both them and for those around them. And so the crisis center therapists assess the situation thoroughly, get as much information as possible, and then render some appropriate recommendations in terms of disposition. These calls are very dynamic. They take, as all crisis center services do, they take place 24/7, all hours of the day and night, all weather conditions, and they involve, they often involve situations where, there are individuals at high levels of distress and, who are experiencing any number of mental health symptoms. And so these are very dynamic situations. We've been fortunate, in the 20 years that the crisis center has been partnering with the police department to have effective, very safe outcomes for individuals, on these calls. There's been a real progression in terms of skill level and a cooperation in working together cohesively to affect safe outcomes for these individuals. Okay, so this slide is just to give a sense of what the expansion is going to entail. As Dr. Santiago had mentioned, there's going to be 3 teams currently that will be operational in the county as of Monday at 7 a.m. The primary team will be operated out of our crisis center in Rockville. That will continue to be 24/7. And the zip codes and the geographical regions that team will cover is listed. And then there's going to be a team down county and a team up county. So we have a team located in Silver Spring and then a team in Germantown. And as we mentioned, we hope that this will reduce response time and make these clinicians more available to the entire community. The mobile crisis outreach referrals can come from any number of sources. Because of the strong partnership the Montgomery County Crisis Center has built with the Montgomery County Police Department over the years, many of the referrals have historically come from officers themselves who respond to thousands of calls for service with individuals experiencing some levels of mental health distress. And so, so many of the referrals actually come from police officers who are on the scene of a situation where they know that there's a mental health emergency taking place, but they're not quite sure what the most appropriate disposition might be. And so they request that the mobile crisis outreach team respond to assist with an evaluation and to help provide the most appropriate outcome. And then some of the other referral sources, certainly the school system, our shelter providers, and our community private providers as well. Any concerned citizen who sees someone experiencing or knows someone experiencing a mental health issue or concern can contact the Crisis Center to inquire about the appropriateness of a mobile crisis outreach. I'm going to touch base now. I'm going to shift and touch base a little bit on my position within the Montgomery County Police Department. And I just wanted to provide a little bit of structure as to what our team, who's involved with our team and what our team looks like within the Montgomery County Police Department. As I'm sure many of you know, the Montgomery County Police Department is a large department. It has almost 1,300 officers. So our team consists. Actually, the dedicated crisis intervention team consists of 2 full-time officers who are Officer Scott Davis and Officer Mike, our coordinator, Officer Scott Davis and Officer Mike Chimblum. And then I was added, and I'll go into that a little bit more in 2015 to the team. The Crisis Response and Support Unit also includes our autism and IDD, intellectual and developmental disability outreach officers, Officer Coordinator Lori Reyes and Officer Tara Bond, who are incredibly passionate and dedicated to working with individuals in the community and connecting them with appropriate resources within the service continuum. Our team now falls under our Community Service Engagement Division, which is led by Captain Stacy Flynn, and we are hoping to add a full-time sergeant position as well, and the vacancy announcement has been put out for that position. So we are a small team within a very large department. And we do have, these are centralized officers. We do have hundreds of decentralized CIT trained officers, and I'll just touch on that a little bit more. My position, like I said, started in 2015. It was initially a contractual position. In 2019, it was changed to a full-time funded county position. Again, I'm a full-time HHS employee, but I am assigned full-time to the crisis intervention team. And my role within the department, I'm sure there are a lot of different questions about the difference between my role and what the Crisis Center does. And so my role primarily, I serve 3 different functions within the police department. One is to assist with conducting mental health evaluations, not so much in the emergency situations that the mobile crisis outreach teams goes on, but the reality is that officers interact with individuals experiencing mental health distress in so many different ways. You know, whether they are investigating crimes, whether there's an issue of, you know, perhaps returning a firearm, whether there's an individual who's been, you know, a survivor of a violent crime. There's so many different situations where, you know, where our officers are encountering individuals with mental health distress. And we, and I assist, when contacted, I assist with those specialized assessments. And I also serve as a mental health consultant on the crisis negotiation team for the department, which is when there's a high acuity situation, you know, where someone might be threatening to harm themselves or harm someone else. And they're, you know, maybe they're barricaded with weapons or something like that. So these are the larger scale responses for very acute and potentially dangerous situations. Okay. Our crisis intervention team training is something I'm very proud of. It's something that we have developed over the past 20 years. Our team, the dedicated officers, along with the crisis center staff, provide a breadth of training opportunities for officers throughout the year. In 2017, then Chief Manger signed on to the International Association of Chiefs of Police One Line campaign, which was a commitment to train 100% of officers on CIT, mental health, first aid, or both. And we did, we were successful in meeting that mission, where by the end of 2019, we did have 100% of our officers either trained in CIT or mental health first aid. The CIT training, as many of you know, is the 40-hour training that we offer our CIT officers. This is a national program which has been developed since the late 80s. It's widely considered the most utilized training in behavioral health services for officers. And we partner with the Crisis Center partners with the police department to offer this training, usually about 4 to 6 times a year, starting in 2000. My team also teaches our mental health first aid for our officers. It's an 8-hour curriculum. It's internationally recognized, and we utilize the public safety model. So we have currently over 700 active decentralized CIT officers. I believe that's even higher now. I apologize. We just graduated a class. And so we really are proud of the work that we've done over the years with our officers. CIT has always been, CIT training, the 40-hour CIT training has always been a prerequisite for officers to become certified in carrying a taser. For those of you who don't know, tasers are the tool or the device that provides some level of paralysis through electric charge in highly acute situations. And for anyone to carry a taser in the department, they have to go through CIT and be successfully CIT certified first. And my last slide, I just wanted to emphasize that, we've really made great strides in our training. All officers on our department are now going to be receiving at least 48 hours minimum of behavioral health training, which includes the mental health first aid training while they're recruits in the academy, and then the 40-hour training of CIT during their first year of service. And the training will remain a prerequisite to carry a taser. So historically, the CIT training has been voluntary. Moving forward, that has changed. Officers who come onto the department will be required to go through the CIT training. And with that, I'm sure there are questions, but I will turn it, in the interest of time, I will turn it over to Ben. Thank you.
All right, thank you, Beth. Again, my name is Ben Stevenson. It's a pleasure to be with you this evening. Again, I'm the Prevention and Harm Reduction Manager for Montgomery County, Maryland.
Hello, everybody. We're having a slight technical difficulty due to the storm. So we are about to pause for 1 second, and then we'll do a couple questions, Ben, before you start. Is that okay?
That is fine.
All right. So, Tim, do you want to come on? I have a couple questions that you can answer real quick.
Sure.
Sure. So we have a question for the Cahoots is they wanted to know, sorry, lost my spot. What is the triage criteria that you guys use, particularly related to weapons when they're present, and does it differ if there's a gun versus a knife versus a tree branch?
Yeah, that's a really great question, and it absolutely does matter, what it is. When our dispatchers are determining relative acuity, and again, we're using, the larger public safety system dispatchers. So these are the same folks who've been through the training to triage, calls for police, for CNT, as Beth was talking about, for paramedics. Specifically with weapons, there's some questions that are going to be asked around, like, how is that weapon being, how is that weapon involved in the scene? You can say that somebody has a knife, and that could be somebody who's menacing and coming at you, ready to go. Or it could be somebody who's just walking down the street. It's a neighbor experiencing homelessness, and they do carry a larger knife on their hip, but they're not menacing. It's secured with them, right? Those are totally different situations. And so our dispatchers are really looking to see not just if there's a weapon on scene, but how is that being utilized? What are some of the other, what is the other information that we need to really better gauge, the threat potential there? If there is ever concern for responder safety, then those are situations where we may choose to respond alongside an officer. And then after we've gotten to that scene together and done some initial de-escalation, we can determine, whether that patrol officer is still needed on scene.
Okay, great. And another question that we had from Facebook Live, I'm going to find that now. No, Ben, you're fine. You can stay right there. We're going to get to you in 1 second. So the question, Facebook, for those of you who are on Facebook Live, it's hopefully back up now, and you will be able to see this in totality. Okay, so I had a question that says, our current crisis center handles clients that are experiencing acute psychiatric crises and active psychosis. Are these the clients that Cahoots handles as well? What do you do with individuals experiencing active psychotic symptoms? Do you take them to a hospital, or do you call law enforcement for further assistance? How do you handle those cases?
Yeah. So we do, respond to, any number of situations where there is, that real acute psychosis. And for us as a voluntary service, what we're looking at is, if somebody is disinterested or unwilling to partner with us in an intervention, what are the other things that we can look at to really determine, this individual's ability to keep themselves and other community members safe? Just because somebody is having a psychotic episode doesn't mean that they're a threat to themselves or to the community at large, right? And so in our responses, it's really about what's going to be the safest outcome for everybody involved. If we are in a position where we do need to get somebody to a higher level of care, and they're unwilling to do so voluntarily, then we will work with partners in law enforcement to engage a peace officer hold, which is an involuntary transport to the hospital for further evaluation.
Great. And so, Ben, why don't you go ahead? Sorry for that brief hold, but we are up and ready. And Ben, it's on you. Thank you, Tim.
All right. Thank you very much, Dornay. So good evening again, everyone. It's a pleasure to be with you. I'm going to share with you a little bit about harm reduction and some of the services that we provide in the county under this space. So harm reduction refers to like the policies and programs and practices that pretty much aim to minimize the negative health and social and legal impacts associated with drug use. They're pretty much grounded in justice and human rights. Harm reduction encourages people to be safer. It also encourages meeting people where they are, as well as encouragement of abstinence. And then it incorporates a lot of strategies that includes like safer use or managed use or even abstinence, as I indicated. Under harm reduction, the services that we provide, and there are additional services outside of just the three that I'm going to discuss this evening, is Narcan, which is our which falls up under our overdose response program. So it's our Narcan training and distribution program. Fentanyl test strips, which is also a strategy that's utilized to educate people about being cautious and being able to test their substance if they're in a person who is in active use. And then our syringe services program, which I'll share a little bit more about that shortly. All right, so as far as opioid response is concerned, it's basically a program which provides opportunities for community members to be trained in Narcan administration. We educate on the signs and symptoms of an overdose, so we will walk a person through what the signs and symptoms look like. We also educate on the steps to assist the person who is experiencing an overdose. We currently do our trainings via a Zoom platform, so we've been able to move to a virtual space where a person could actually register for the training online, as well as receive materials and things like that, and take the training online. We also provide Narcan in a lot of different spaces within the community. So we provide Narcan to a lot of treatment providers in the community to kind of be able to provide them to their clients and things like that, just because we know since COVID, a lot of people have been isolated and dealing with a lot of, stress and depression and anxiety of not having that human contact as normal. And so just being in a space of being able to provide Narcan has just really been able to equip people just in case. We also provide Narcan to family members. We've actually been able to increase our efforts with our fire and rescue partners. So we are able to equip all of our fire and rescue vehicles in Montgomery County with Narcan, as well as with Narcan in the fire stations, as well as working with our Department of Correction partners within our jail addiction services program. They've been able to provide kits to inmates upon release. this is a very viable strategy in regards to ensuring that there's a Narcan in the community. So we've seen numbers that have shown that Narcan can actually decrease the overdose fatality rates by about 20 to 30%. And we've also been able to incorporate the utilization of peer support specialists within our harm reduction services program to actually go out and train people on the street and educate them, just like I said, about the signs and symptoms and how to save a person's life as well. Another important aspect of our Narcan training program is the Good Samaritan Law, which is a law that protects an individual from arrest and prosecution for certain crimes when they actively engage in an emergency overdose situation in regards to trying to help someone or trying to if they're the person that calls 911 and things like that, it protects from, arrests, prosecution, or any additional charges, as well as a few different misdemeanors. As far as our fentanyl test strips, a lot of times what we do is we put our fentanyl test strips within the Narcan kits, just because we have we know that fentanyl is often described to be 80 to 100 times stronger than morphine and 50 times stronger than heroin. And so being able to provide people with fentanyl test strips allows them to actually test their substance before they actually use. So it hopefully puts them in a space where, one, they have Narcan. It encourages them to go slow, to never use alone, and then to also have someone to kind of check on them if they do use alone. And so we educate a lot of friends and family members on these, just to try to ensure that people who use drugs actually have access to these fentanyl test strips so that they can test their substance before using. And these are just a simple, inexpensive, evidence-based method of averting drug overdoses. So it's really hoping to try to sustain life so that we can lead a person to a path of pursuing their treatment and pursuing their recovery. And within Montgomery County, since 2016, about over 60% of all of our fatal overdoses have been related to fentanyl. So just trying to ensure that everyone has that education and awareness about the dangers of fentanyl, and having the tools that they need as well. Last but not least, we've also been able to during the pandemic is actually build up a syringe services program. So mainly it's utilized to improve health outcomes and prevent disease transmission, facilitates engagement of people who inject drugs in ongoing services. So in addition to providing like clean syringes, different other harm reduction supplies and things like that, we have peers that work in that program that are able to engage clients and foster relationships, and hopefully, foster and build rapport with those clients to lead them to a path of pursuing their recovery. It also reduces syringe reuse by ensuring people who utilize the SSP have access to, like the clean points and things like that. And then we also, within that program, are able to provide wound care services. So a client can come in, and if they have issues dealing with wounds and things like that, we're able to provide services and support for that, as well as education. And then we're also able to provide free HIV and Hep C testing within the program as well, which is rapid testing. So we get those results pretty rapidly, and we can kind of, triage and assist the person to find different services to kind of support them with their needs. Currently, the Syringe Services Program is a fixed site program. So it is housed at, soon to be housed at 1500 East Goody Drive, co-located with our medication assisted treatment program, as well as our drug court program and urinalysis program and things like that. So it's definitely, we also are able to provide, like reproductive health education and additional services as well. So as far as our programs are concerned, some of the resources that we work with and things like that is our access to behavioral health. So just like I said, we work to try to foster relationships with clients that enter into our program, but we also try to lead them to a path of pursuing their recovery and their treatment. If a person wants to reach harm reduction services, they can reach us at the 240-777-1836. That way a person could actually get Narcan information, they can get refills, they can get information about the syringe services program. They can receive fentanyl test strips as well as the HIV and Hep C testing. And then also peer support services. Which you can contact through the Crisis Center, which is the number on the screen, the 240-777-4000, which you can reach a steer peer, which is stop, triage, engage, educate, and rehabilitate. And these peers are actually deployed out when an overdose call comes in. They're either deployed out to the overdose incident or to the hospital to try to engage with the victim or with the family. So one, provide them with Narcan, but also provide them with different resources and things like that. So if you're ever in a position to are interested in wanting to get trained on Narcan administration, or know of someone who might be struggling with their use, but they're just not quite ready to venture into the space of treatment and recovery, please point them in our direction. Just because we're trying to help as many people as we can, one, to mainly sustain life, so hopefully we can lead them down that path of treatment and recovery. So thank you for having me tonight, and
Awesome.
I will turn it over to Dornay.
Thank you. And before we start the question and answer, we are honored to have our county executive, Mark Eldridge, with us. And he will give us say a few words. We're going to unmute him. And this is a topic that's very near and dear to him. So hopefully we can unmute him soon. All right, are you ready? No? All right, so while we're working on that, everyone, we will go to our question and answers. Thank all of our guests.
Hello?
Oh, there you are. Go ahead, sir. We can hear you.
Okay. Sorry about that. I've managed to listen to all of this while trying to get signed in a million different times, but I'm finally here. So catch my breath here a second. Yeah, I was going to originally talk about, introducing everybody to Cahoots and all the work that Cahoots does and what the context was for Montgomery County. So I got to listen to their presentations, which were great, but it's some of what I was going to talk about. So I'll talk about some other things that were important to me. First of all, you're right. This and our mental health responses in the county have been, I think, a major issue, particularly as, we've looked at some of the police shootings in the county. In the last 4 shootings, every one of those folks was dealing with a mental health issue at the point they got shot. And we didn't really have other tools available to bring to the scene. And I know that that's one extreme of where there's a need for mental health interventions, but it's the most dramatic extreme because in all 4 cases, somebody lost their lives. And we need to be able to put people in the field who have the ability to talk to folks and can buy time and can, whenever possible, de-escalate situations where there's the opportunity to de-escalate. And even if buying time means that an officer has enough support that they don't have to shoot somebody, that would be a worthwhile ending as well. So that's from one level of my concern. The other side of it is things we see every day, like in Silver Spring with the drunk and the homeless, and the struggle those folks have, and the kind of homelessness to prison, repeat pipeline, and the fact that our only response always seems to be the police, and doesn't end well. I've talked with guys in the homeless shelter who have repeated arrests, for the same kind of things. I have people who have been arrested for failing to appear on a warrant. All those things just complicate their lives, make it more difficult for them if they can recover to move forward, because a criminal record is just one more obstacle for people to overcome. So these are things that have troubled me for a long time, and I've wanted very much to be able to enhance our mental health supports. I know that we've got a great team, and they're well-staffed. We have really good people on the team, but we have one team, and this is a big county. And I would venture to say that wherever you would locate one team, they would never arrive in time in most cases to make a difference, particularly in some of these police encounters. Never could have gotten there in time to have made a difference in the outcome. So increasing the number of teams, and I hope this is a down payment, not the end of what we do, but getting to the point where we've got teams who can arrive quickly where they're needed is of the utmost importance to me. We've got 15 years of a mobile crisis team and an outreach team, and they've proven to be able to prevent behavioral health crises from escalating. And so we know we can do it. We just don't have the ability to do it when we need to do it all the time and where we need to do it. And so that's my goal. With the council's support, we've appropriated enough money for 6 new therapists so we can expand these teams. And I'm really happy that, the 2 satellite offices will be opening on Monday the 30th. That's a big deal. And like I said, I hope it's a down payment. I think it's going to give us more tools to work with. We desperately need a restoration center, and I know Raymond mentioned that they're going through the program requirements, and I'm hoping that my intention is to put that in the budget this year and get this up and standing as soon as possible. That's another case where, it's an opportunity to take people to a place where they can get help, where they can sober up or whatever they need to do overnight and not have to rely on the jail as a place to house them. I think all of you know the jail is our biggest mental health facility in Montgomery County. We've got 30% or more of that population that presents with mental health issues. And many of them we need to figure out how do we deal with in the community and how do we address the underlying mental health issues instead of using jail as the place to do it, and instead of allowing them to get to the point where they do things which inevitably put them in jail. So it's my pitch for the Restoration Center, which I think is one of the really important things that we have to be able to move toward. Was very interested in cahoots the first time I heard about them. I had actually community meetings with folks who talked to me about the value of cahoots and why it was important. We had meetings with them before COVID hit us, and I was very impressed by what they're capable of doing, and I'm really optimistic that they'll bring a focus and a perspective on what we're doing here that lets us be successful in putting a program into the field. Not every call can be answered by a cahoots team without a police officer. There will be calls that will definitely require police backup and support, and there will be calls that ultimately be dealt with by the police. But we need to have the capability to have a full range of responses, and that's why I'm so happy and why I waited on the phone and struggled to get into this, because I wanted you all to know how important this is to me, and that I see this as the beginning and not the end of the work we're going to be doing in this field. So thank you for giving me a few moments tonight. Thank all of you who are working on it, and the folks from Cahoots who really engaged us in this. You can make the county a better place and a safer place, and I look forward to that.
Thank you so much, and we're so happy that you were able to make it. So we have lots and lots of questions in the Q&A. So Athena and I are going to just start going through them. I'm going to try and point them to the correct person who I feel would be best to answer them. Anybody can jump in after that, okay? So there's an interest. I'm going to direct this to the doctors, Dr. Santiago or Dr. Kroll. They are asking to learn more details about the criteria that will be used to determine when armed law enforcement will be a part of the response, who will be making the decision, and what training will they receive to exercise that discretion to include or exclude law enforcement.
I'll venture a response. And I think that Dr. Kroll, but also Beth might want to comment as well. We know that Beth mentioned a lot in one of her slides, the kind of training that they're doing in the police department, and also the changes, increasing requirements for CIT training, which includes a lot of the topics that we talked about here, especially that 40-hour training. So, and a lot of those discussions and training has to do with how to use the minimal force in responding to mental health crises. That is a culture change that is taking place as we speak in the police department, at least from the perspective that I've seen the discussions. And I think it's going towards the vision that that our county executive just expressed right now. He expressed it as a concern. I think we all have it, and also as a vision that eventually we'll come to the point where we can respond to situations where there's weapons involved in a way that does not require another weapon responding to that. But we do have the mental health supports to address those situations and de-escalate the situation and use harm reduction procedures and so on. Dr. Kroll or Beth, do you want to comment further?
Go ahead, Dr. Kroll. I believe you may be muted because we cannot hear your response. Okay, so I'm going to come back to that question. So Beth, we're going to have you respond after Dr. Kroll when he comes back. So they're also wondering what specific criteria other regions, and this is for you, Tim, and you're muted. What, like outside of other regions that are using cahoots, such as Denver, et cetera, how do they apply police involvement criteria and priority regarding weapons, if you're able to answer that question?
Yeah, I can speak to that in broad strokes. And what it really comes down to is really time in development with the community led to really designing their responses in those more violent situations. I'm not going to be able to, quote you on specific policy, but a lot of the design and response, regardless of the acuity of the situation, was community driven. And in particular, in Denver, there was a ton of really great work done really early on with both service providers and community members who identified as, being part of impacted populations. And through that work together, they were able to really identify, a very specific protocol and really orient their responses around what it was that the community was really asking for.
Okay, and Tim, while you're talking, the next question for you is, in Oregon, for transport when there is an involuntary need for a patient to go to a hospital, do you guys use police to transport, and are the clients handcuffed? Yes.
If we get to the point in a situation where a patient we're working with needs to go to the hospital and is unwilling to do so voluntarily with us, then the only other option is in handcuffs in the back of a patrol car. But before we get to that point, there's an opportunity for us, even if we do have that officer on scene already, for us to really sit down and discuss the situation, right? Our patients are the experts in their lived experience, and so we really try to, whenever possible, really articulate the severity of the experience and say, look, we can't leave you here, and if you're choosing not to come with us to the hospital, this officer is going to have to take you, and so it's really about how can we empower the patient to make decisions that keep this in that voluntary space. And if we do end up in that, least ideal outcome of an officer transport to the hospital involuntarily, the COOTS team still follows, and we still facilitate the same transfer of care form that we would have filled out and presented if we had been the ones doing the transport ourselves. And that allows us to really further our patient advocacy and provide insight to, what was going on in our interaction with that patient maybe before law enforcement showed up. Was there a turning point where we lost the rapport that we're rebuilding? And is that something that could be really considered by crisis workers in the hospital? Or were there other extenuating circumstances that prevented us from remaining a voluntary interaction?
Awesome. So Ben, this one's for you. Can you maybe in the question answer, reply and let them know which statutory source of the Good Samaritan Law you were referencing?
Oh, sure.
Thanks. Sure.
So I was speaking specifically to, let me make sure, I'm gonna pull my notes up so I don't make any mistakes.
Sure. And if you don't want to say it out loud, you can also type it in the Q&A and everybody will be able to see that as well. It's up to you.
Oh, okay. All right. I'll put it in the Q&A so it'll be specific. All right.
Sure. That's great. Okay. So another question that I can actually answer says, on Monday, when the mobile crisis teams are up, will they be staffed 24/7 at all 3 locations? If not, what are the highest priority times? 2, will those times be fully staffed at all 3 locations? And what is your metrics for an acceptable response time for the mobile crisis teams? So I can say that for the mobile crisis teams, they will not be 24/7 at all locations to start. Rockville will remain 24/7. The satellite offices will be staffed 16 hours a day, Monday through Friday, from 7 a.m. to 11 p.m. And you'll see it's also on the slide on the screen right now. I had a feeling people were going to ask that, so we did post that. And so there'll be 3 teams Monday through Friday, 1 team at Rockville, 1 at Germantown, and 1 at Silver Spring. And an acceptable matrix that we are hoping is that our response time will be out the door within 10 minutes of receiving the call. So that's where we are with that. And there was another question. So, and Dr. Kroll, are you able to speak yet? Do you think you want to try again? You're on mute. Nope, nothing. Okay. So then I'm going to field this to you, Dr. Santiago. The question is, it seems as though the Crisis Center and Montgomery County Police Department have been able to forge a very strong alliance and partnership throughout the years. Why is there an attempt to dismantle this partnership? Instead, could we consider other avenues to train law enforcement?
Yeah, I'm not aware that we're trying to dismantle that partnership. On the contrary, at least in the time that I've been here, we've been forging the relationship in a stronger way. Like I mentioned in my remarks in terms of developing the Crisis Now model, one of the dreams and one of the goals is to create an integrated call center, common triage protocol that can be used by 911, which is the way that emergency calls usually come. And that's how the police department is alerted. We're talking about having that common triage protocol that can be used in 911 at the crisis center, the call number there, and 311, and so on. And so we're, I'm not sure where the impression is coming that there's a distancing. What we have been talking about is identifying those situations where the mobile crisis outreach team can respond safely without a police presence. That we have been talking about, but that should not be interpreted as breaking a relationship. On the contrary, we are making every effort to make sure that we maintain, even in those low acuity situations, maintain communications with the police department, so they're fully aware where we're located, what we're doing, and so on, in case there is a de-escalation. That's following similar to what I heard Tim Black talk about in terms of what they do in Eugene, Oregon. There's a very strong partnership in communications with the police department. I hope that helps
Awesome.
answer.
Yes, that was very helpful. Dr. Kroll, do you want to try again?
Let's try one more time.
Yay!
Yes.
We can hear you now. Okay, so this one is for you finally. So Cahoots appears to be designed to address the specific needs of the homeless population in Eugene, Oregon. How does that translate to Montgomery County, which has a very diverse population of over 1 million residents, and the role of mobile crisis teams appears to be to evaluate individuals in acute psychiatric distress?
So it's a good question. Thank you, and I'm actually glad to be able to talk again. The first thing is that it's important for us to know that as we talk about crisis now, and you've heard the team describe it, that it is not, our mobile crisis response in the county is not just the crisis center teams that we've been building and expanding. We have outreach teams that do outreach to the homeless community. We have a peer program called STEER that does outreach to folks who are in overdose conditions in hospitals and in community. We have our mobile crisis outreach team, of course, but we also have CIT that will do outreach to the community depending on the need. And so when the value for us in having Tim with us and talking to us about Cahoots is a particular way of thinking about how we triage those calls, how we make decisions about whether or not someone is, what the levels of safety or risk are, and how we identify over time whether or not a person is a response from law enforcement is needed or a civilian response will cover it. So the goal for us is to try to work through triaging who will respond to which call. Expanding mobile crisis out, I think, is purely is in part because a lot of the folks that are on the streets do have mental health issues, and will continue to have mental health issues. But this is, we don't describe it this way, but as I think about it as human service response protocol. So it is homelessness, it is mental health issues, there may be substance abuse issues, there may be a number of things that are going on the streets with a person that would require a response from the human services system. And one of these teams should be available to respond. So that's the, at least a piece of how I see the difference between what happens in Eugene, Oregon and Cahoots. What Cahoots brings to us, I think, is a way of thinking about it and beginning to triage how those calls get responded to, and a particular approach to dealing with people on the streets that is based in person to person and without the authority necessarily of law enforcement. I will underscore what Dornay has said and what Rolando has said, is that this does not mean that we are disconnecting from law enforcement. It means we are shifting how we work and expanding how we work to accommodate the differences in needs that people have and differences in things that they present to us on the streets. I hope that gets to the question.
Yes, thank you so much. And I'm going to mute you, Dr. Kroll, because there's some weird background, and then I'll take you off. Everybody's muted right now, in case you're wondering. I was trying to get rid of the noise. So another question is, and I wanted to get this one second from I understand the need to have more mobile crisis teams out in the community, but where will individuals be referred to for ongoing mental health services? Are there more community mental health clinics being expanded in the county as well? And that can be for anyone who would like to respond, Dr. Kroll, Dr. Santiago. Remember, you're on mute before you speak.
Yep, I can start, but I think Dr. Kroll will want to talk about this since it's a fairly new initiative. But one of the ways that we're trying to think about reaching out to persons with mental health needs is having the role of navigators, which is more of an individualized approach, and it's sensitive to the individual needs of the person, and it's having people that will connect with you and are very highly knowledgeable of the services in the county, both those provided by the county government as well as those in the nonprofit sector, and are able to walk with a person with their needs until they're able to feel like they're on their 2 feet and on their way to recovery. But I know that Dr. Kroll has had this vision for a long time, and he should speak about it.
Thanks, Dr. Santiago. I think there are a couple of things around this. One of them is that Montgomery County has an incredible wealth of mental health services in the county and resources, probably more than any place I have worked in my entire career. Sometimes it is a matter of connecting people to what they need. So the navigation piece for us gives us a chance. The navigation model that Rolando was talking about gives us a chance to make sure that we can follow up with someone and can engage with someone, so that once the crisis team or the outreach teams have identified them and they've identified a need, we can stay with them and follow up and make sure that they get to where they need to get to, whether that is a residential space or a crisis respite bed or some support for housing or some other support that they might need to help to promote their wellness and safety. So we are building that as we speak, not as a part of the mobile crisis outreach team, but a part of the larger effort that's underway in the department to try to do a better job of integrating and connecting all the different kinds of services that we provide in the county, and not just to the county, but to our provider network as well. There are providers out there that are not county employees, but they're under contract, and sometimes they're just simply Medicaid or private providers that are available to our county residents. Our goal is to build a system that we can refer people to, so that they can get whatever it is that they need.
Awesome. And this is for you, Tim. So the question is, with Cahoots, is it their staff, not the police or a dispatch call center, that triages as to when or whether the police need to accompany or stay on site?
That triage process is handled primarily by dispatch, but when there are really extenuating circumstances, something that's really exceptional about the situation that Cahoots is going to be called into, there's opportunity for dispatch supervisor, and the response team that they want to send the call to talk on the phone about it in a little bit more detail before an ultimate decision is made. So there's I guess generally dispatch triages everything for us, but they can call our teams and talk about it if there are any questions.
Okay, and Tim, while you're on, last question for you. Is the Cahoots team made up of licensed clinicians?
No, we do have a handful of licensed clinicians who work as responders as well as clinical supervisors for the team. But because we're not doing any diagnostic work, we're not placing holds on anybody ourselves, we don't require a master's level credentialing to be a part of the Cahoots team on the mental health side. I mentioned this early on in a slide. In Oregon, the credentials for a qualified mental health associate generally are going to cover the experience and education that somebody needs to come and work on the Cahoots team. But it's also important to recognize that a lot of this work is about meeting people where they're at, and is about kind of some intrinsic skills that are hard to teach. And so some of the best Cahoots responders that we have ever had were folks who were bartenders or bouncers or baristas, and learned really, that communication, that value of community and connection, concepts like self-medication, even how to set boundaries and limits with folks, So we try to cast a pretty broad net with our recruitment. And in addition to that, kind of school experience, we do have several members of our team who identify as coming from a place of lived experience, and in other positions have carried a peer support credential in the past.
Awesome.
Can I add something to that?
Absolutely.
Tim reminded me of two things that I wanted to say. One of them is that has to do with the difference in the cahoots and the pieces we're building with Crisis Center is that there are that lived experience and that connection, and is part of how we're building out our crisis teams and training our folks so that they can respond based on the human relationship with people rather than from a place of authority. But we also recognize that there are times in the populations that we serve where an involuntary admission or emergency petition is going to be necessary. And so having master's level or licensed clinicians available for that purpose is something that is a necessity of Montgomery County, I think. So it's one of those places where we might differ some. The other thing goes back to the comment about triage. And I think Tim would agree with this, but triage is a continuous process, starting with the phone call, but also evolving as the situation evolves. When someone hits the community and gets to a person and is engaging with a person, if they see something that changes the dynamic of the situation, then they adjust and adapt. Whether that is sometimes it's going with law enforcement and then deciding we don't need law enforcement here, we've got this. And sometimes it's going solo and deciding we probably need to have some backup here. So it can go in a bunch of different directions, but it happens not just at the point where the call comes in, but it happens in real time. And that's another facet of the training that's important in this process, is teaching people situational awareness and to be alert and aware of what's going on around them at all times so that they can make those decisions as they're doing their work.
Awesome. And then, so this is for you. No, I'm not gonna. For you, Dr. Santiago, it says, what will the factors in deciding if someone will go to the Restoration Center versus the Crisis Center when it's up and running? Remember, you're on mute.
That's an excellent question. Thank you for asking it. The Restoration Center is especially appropriate for individuals who are having a crisis. They're having a suicide attempt, or they're intoxicated. They've been close to an overdose, but not quite, and they need a place to stabilize for the first day, second day, maybe even 3 days. And it's an alternative, as we have said before, to an emergency room. They don't need an emergency room. They just need someone that listens to them. Also, some medical attention. So certainly we will have nurses and physicians, persons that can attend to their medical needs. But also they need therapists. They might need a psychiatrist. They might need a social worker, because we want to also connect them to services. We don't have that capacity at the Crisis Center for that kind of stabilization is a word that we've been using, stabilization response. Having said that, in addition to thinking about a building, a restoration center, lately we've been thinking about habilitating a room at the Crisis Center where we might be able to provide that service. We have applied for a SAMHSA grant. We don't know if we'll get it. That will provide us with the staffing, the nurses for 24/7. So the distinction of the Crisis Center service is that anyone can come at any time, and sometimes the police department drops off individuals whom they feel need an assessment, but oftentimes it's after the crisis has happened. And but most of the time, if people have an acute crisis, they're sent to an emergency room, and like we've said, oftentimes land in jail. So we want an alternative. That's what the Stabilization Center, Restoration Center is for.
Great. So I hear you saying it's more of a medical component than the Crisis Center. It'll have more medical pieces to work with clients who may be suffering from substance abuse or mental health, and determine what those factors are.
Absolutely.
Awesome.
Well
So
said.
So we have come to the point where we're going to start having courageous conversations and questions. So anyone on the panel can jump in with this one, with these next questions. Why are we training officers in CIT when they should be diverted to mobile crisis units?
I'd like
Beth?
to jump in. Oh,
Okay,
Dr.
go ahead,
Kroll,
Beth.
sorry. Would you like to go first? If I can jump in just briefly, then I'll pass the baton to Dr. Kroll. So my perspective is that it would be disingenuous for us to think that we're ever going to completely remove officers from responding to individuals who are having mental health symptoms. You know, there are many, many different situations where individuals in the community call the police. You know, and it may not be it may not be that they're self-identifying as having a mental health emergency, or even their family might not be identifying them as having a mental health concern or exhibiting mental health symptoms. But they're, you know, for any number of reasons. You know, someone could get into a car accident and be under stress, or their symptoms may become more pronounced because of a traumatic situation. You know, someone might have their wallet stolen, or, you know, someone may have an argument with a family member. And so there are so many different situations where officers encounter individuals who are having different types of symptoms. And 20% of the population, and probably even more so over the past year or two with COVID, you know, 20% of the adult population does carry some sort of mental health diagnosis. It's a huge percentage of our population. So I don't think realistically we can ever extract our officers, you know, from interacting with folks with these types of symptoms. We want them to be well prepared. You know, we want them to have the tools and the knowledge and the skills to work effectively with individuals who are having these issues, and then also be able to have a breadth of knowledge of the resources available. So, you know, during CIT, it's not just about teaching the clinical aspects of the illnesses, but also saying, you know, these are your resources. These are the staff at the crisis center. They get to know them. They understand. They you know the staff by name. They know who to call. They meet with people from the STEER program. They meet with people from NAMI, you know, the National Alliance on Mental Illness. So they really get a broader understanding of the resources available, so they can properly, you know, refer individuals who have needs to the appropriate resources. Dr. Kroll?
Thanks, Beth. I think you've done a great job of answering that question. I would simply add that there's a reality of the thousands of calls that law enforcement gets that come through 911, through 311, through all of our systems every year. We are not with 6 mobile crisis teams or even 10 mobile crisis teams going to be able to respond to all of those calls and eliminate the need for law enforcement to respond. There will always be a behavioral health, a mental health element in a great number of the calls that they respond to, whether or not they are identified as such. Having law enforcement trained to de-escalate both the situation and themselves, and having law enforcement available to know have the skills to know how to do that and what those resources are, only helps law enforcement and only helps the community for us to be able to dial down the risk factors for the citizens that they interact with and for themselves. I would love a society where law enforcement was never called for anything, but I think that's not realistic in anytime soon. We are building towards the capacity to do multiple responses: a mental health response, a non-police response, but also a police response that is staffed by officers who are trained and who have CIT training and background and know how to do that, know how to step into a situation and de-escalate it and be aware of the potential for mental health problems at any time that they're interacting with someone.
Thank you. So this is our last question, and thank you, Athena Morrow did mention in the question and answer that even if we don't verbally respond to all of your questions, we will give you answers in the Q&A so that you can reference that and have that information. So I'm going to combine, this is another courageous question, and we're going to end on this one. So I'm going to combine 2 together. It says, can someone clarify how the system in Montgomery County is going to change, aside from more crisis teams, all officers getting CIT, and the creation of a stabilization center? Aside from the increase in mobile crisis teams, in what ways will the county be reducing the number of mental health calls to which armed law enforcement will be dispatched? The second part of that is, will police escort on the crisis calls continue. It is unclear that the Montgomery County teams sees itself as pivotal in reducing police violence towards Black and brown people of color in distress. So basically, what are we going to do that's going to be different besides expanding the team and the Restoration Center? And how will the teams look? Will there continue to be a police escort? And I can assure you that it's very clear that we do see ourselves as pivotal in reducing the police violence, but I'll let the rest of you respond to that as well. If we see ourselves as pivotal in reducing police violence towards Black and brown people of color in distress.
I'd like to think that we are going towards that dream that the questioner provided, that we want all communities, we want Black and brown communities to be recipients of the best efforts, provide a mental health response to when they are in crisis, and not necessarily expect that it's a law enforcement presence that will appear at the scene. We do want to minimize, if not eliminate, the fatalities as we've seen on occasion. So we are fully on board with that dream, and we believe that our efforts are moving in that direction, and we welcome the participation of the community in continuing to press on these issues. We are with the community, and we want to together reach that dream.
So I would add that beyond the technical changes you've heard this evening, that we are looking at what I hope and pray and will drive towards becoming a culture shift in the county, both in terms of who gets called and how we get called and how we respond to situations that involve mental health, behavioral health issues in the streets of Montgomery County. Are we pivotal in reducing police violence towards Black people of color in distress? I would say we are. That this effort that you hear here is part of the CE, the county executives, and the county's larger effort to try to address the issue of disparate encounters between law enforcement and people and Black and brown people in the county. So to the extent that we play a role in that, we are absolutely a pivotal piece of that. If we can do something that actually saves lives, and if we can encourage people, if we can increase the safety of those encounters, because those encounters will happen. The question is, how do we promote the safety? And I think that the related to the MOU, I would expect that there will be opportunities for us to respond solo. There will be opportunities where we will want police with us in some capacity. And there will be opportunities where we will follow the police, where we know they've gone to a scene and then they call crisis to come in and take and lend a hand. So all of those things will still apply. No matter what, the goal is to increase safety and to make sure that people with behavioral health problems, including people who are Black and brown, have an opportunity to be served safely and be treated with dignity. So that is our goal.
And so I was wrong. So the follow-up to that is, when are we likely to have the shift to more cahoots approach from the current Montgomery County model, which seems to be police first and then call mental health team?
The shift is happening now as we speak, and you've heard the indicators through the presentations this evening. We, like the county executive said, this is a starting point. We have some ways to go, and we call on the community to reach out to us, continue to do so with your questions, your counsel, your engagement, because together we can do it.
Absolutely. So, yes, County Executive Mr. Elrich, would you like to have any closing remarks before we end today? You're on mute just in case. All right. Well, Dr. Kroll or Dr. Santiago, it's on you.
Dr. Kroll.
So I wanted to say thank you all for taking the time to come and join us this evening. And just know that this is for us the start of a long-term initiative to try to change how we work and how we operate in the county, and how we bring more safety to our interactions with people on the streets and get them to a happier and to a healthier response. It's the team that you've got that we have here with Dr. Santiago and Beth and Ben and Dorne have been working really hard to try to figure out how to make this work. We will be doing ongoing collaboration with Cahoots and ongoing training and consultation, but also we will be bringing in the best of elements that we can find from across the country to make this a really robust response and a really robust change in how we operate. So there will be, and we will use the knowledge that is here in the county, because there's a wealth of knowledge in the crisis center teams and in the staff that have been doing this work for years that cannot be dismissed. We now have an opportunity to take that and meld all of that together into a better, stronger system for the county. So I'm looking forward to seeing the work of the team and to participating in it and to hearing both feedback, both good and bad, from county residents, good and critical, I should say, from county residents and
Absolutely.
So I want to thank you all again for taking the time to join us tonight.
Absolutely. And I just want to thank you all, the audience, thank my the county executive, my esteemed colleagues for coming here tonight and having this courageous conversation. And we will hopefully have many more of these conversations as these changes roll out and we slowly make this change. We will definitely have more of these conversations, and we invite you to join us. Thank you so much. Good night.